Okay, let's unpack this. We're diving deep today into a topic that might sound a bit technical, maybe. Equine metabolic acidosis.
Yeah, it sounds intimidating, but it's super important for understanding horse health.
Definitely. We've got a stack of sources, clinical guides, expert notes, all that. And the mission, really, is just to pull out the key stuff, the aha moments.
Make it make sense without getting lost in the weeds.
Exactly. A shortcut to understanding what it is, why it happens, and, why it's such a critical thing for horses.
It really is critical, often a big red flag for something serious going on underneath. So, at its most basic, metabolic acidosis, it's a major disruption.
A disruption of the acid-base balance, right. The body trying to keep things level.
Precisely. Keeping things slightly alkaline, actually. When we say acidic here, we mean there's too much acid building up.
Which comes down to hydrogen ions, H+1.
That's the one, an increase in hydrogen ions. And too many of those makes the blood more acidic, which we measure as a lower blood pH.
And for horses, that normal pH is super tight, isn't it? Something like 7.39 to 7.45.
Exactly, a very narrow window. So dropping below 7.39, that's acidemia. You're in trouble.
Okay, and the core problem in metabolic acidosis is bicarbonate, right? HCO3 here.
You got it. It's a primary decrease in plasma bicarbonate. Bicarbonate is one of the body's main buffers.
Like a sponge, soaking up the extra acid.
Yeah, that's a good way to think about it. Soaks up those H+ ions to keep the pH stable.
Okay, so bicarbonate drops. But how does the body normally keep that balance before things go wrong?
Well, body's amazing. It has multiple systems. You've got those Bucker systems like bicarbonate acting instantly. Then the lungs are huge. They control CO2 levels. Breathe off more CO2, you get rid of acid.
Because CO2 makes carbonic acid in the blood.
Exactly. And then long term, you have the kidneys. They're crucial. They can dump excess acid and regenerate or hold on to bicarbonate.
So buffers, lungs, kidneys working together. If they get overwhelmed or you lose a ton of base, like bicarbonate.
Or produce a ton of acid.
Right, then the balance gets thrown off. The sources mention that Henderson-Hasselbalch equation, but the simple version is bicarb goes down, pH goes down.
That's the bottom line. Less bicarbonate means less buffering, lower pH, direct link.
Okay, here's where it got really interesting for me in the sources. Classifying this stuff using the anion gap sounds very lab nerdy.
It is a lab test thing, but it's incredibly useful. It helps us figure out why the horse is acidic.
How does that work? What is the anion gap?
Okay, so it's basically vets looking at the main electrolytes they measure in blood work. Sodium, Ni plus ARDA. That's the main positive one.
Right.
And then the main measured negative ones, chloride, Cl, and bicarbonate, HCO3.
Okay, measured positive minus measured negatives.
Yes.
But there are other charges floating around too, unmeasured ones.
Exactly. Things like proteins, phosphates, sulfates, stuff not on the standard panel. In a healthy horse, it all balances out predictably. The anion gap is essentially that difference.
Na plus minus, Cl plus HCO3.
Right. It represents those unmeasured negative ions that are normally there to keep everything electrically neutral.
And there's a normal range, about 8 to 16 millieql, the sources said.
Correct. Now here's the key. If a horse has metabolic acidosis, we know bicarbonate is low. The anion gap helps us figure out why it's low. It points towards the cause.
Okay, so break down the types based on this gap.
All right, first you've got high anion gap metabolic acidosis, HAGMA. Super common in horses.
High gap. So that number, 8 to 16, it's going up.
Yes, and this usually happens because there's a buildup of abnormal unmeasured acids in the blood.
Like lactate.
Lactate, it's a classic example, and yeah, the most common cause in horses. These new acids, they release H+ ions.
Which uses up the bicarbonate buffer. We got that.
Right. But the negative part of that new acid, the lactate anion itself, isn't usually measured in that standard Cl and HCO3 group.
Okay, so bicarb drops, making the measured negatives lower.
But these new unmeasured negative ions are now filling the space, electrically speaking. So the gap between the measured positive sodium and the lower measured negatives, Cl and now low HCO3, widens. It goes up.
Got it. The increased gap tells you there are extra unmeasured acids floating around, like lactate or uremic acids from kidney failure, you mentioned?
Those are the big ones for HGMA in horses, lactate especially.
Okay, that makes sense. What about the other one? Normal anion gap.
And GMA.
Right, anion, sometimes called hyperchloremic metabolic acidosis. This happens differently. Usually it's from losing bicarbonate directly from the body.
Like, is serious diarrhea, losing fluids.
Bingo, diarrhea is the prime example. Horses lose massive amounts of bicarbonate-rich fluid from their gut.
Yeah.
Total body bicarbonate just plummets.
And the normal gap part, how does that work if bicarb is low?
Good question. To keep the electrical charges balanced in the blood when bicarbonate goes down, the body often compensates by holding onto more chloride. Chloride ions are negative, remember?
Ah, so chloride goes up as bicarbonate goes down. Often, yes. So if you look at the formula again, Ma plus minus, Cl plus HCO3, the chloride might go up enough to sort of offset the drop in bicarbonate.
So the overall calculation, the gap, stays normal-ish.
Exactly. The gap itself hasn't widened because of new unmeasured acids. The problem is the direct loss of bicarb, or sometimes adding too much chloride, and the body swaps chloride for bicarbonate charge-wise. That's why it's also called hyperchloremic high chloride.
Okay, wow. So HEMA, new unmeasured acids like lactate, and AGMA equals losing bicarb, like in diarrhea or gaining chloride.
Yeah.
That actually clarifies it a lot.
Yeah, it helps categorize the why. The cause really dictates the type.
So let's dig into those causes. Why do horses actually get this? What are the common triggers from the sources?
Okay, high-ending gap side first. Lactic acidosis, we said it's the most common, most clinically significant, and it's usually type A.
Type A meaning lack of oxygen, poor blood flow.
Exactly. Poor tissue perfusion or hypoxia. And the sources are crystal clear on the main driver here.
Colic, gut problems.
Colic and severe GI disease, absolutely. Things like a strangulating obstruction, a twist, an entrapment where blood supply to the gut is cut off, or massive fluid loss from acute colitis, proximal enteritis.
So the gut tissue isn't getting oxygen, switches gears.
Switches to anaerobic metabolism, yeah, and just starts churning out massive amounts of lactate. That's the big one.
Makes sense. What else causes type A?
Well, anything causing widespread poor perfusion. So severe dehydration leading to hypovolemic shock, systemic inflammation like endotoxemia or SIRRs, severe respiratory disease where oxygen delivery is compromised. But gut stuff is really number one.
And type B, non-oxygen related.
Less common, but things like severe overexertion tying up, liver failure because the liver normally clears lactate. Grain overload can cause it too, partly through lactate production and fluid shifts.
Okay. And you mentioned kidney failure earlier for HEM.
Right, uremic acidosis. If the kidneys fail, acute or chronic, they just can't get rid of the normal daily load of metabolic acids, and they can't conserve bicarbonate properly. So those acids build up. High anion gap.
Any other AGMA causes worth mentioning? Ketoacidosis, toxins.
Ketoacidosis can happen with starvation or hyperlipidemia, but usually isn't severe acidosis in horses. Unlike in diabetic humans or dogs, severe diabetes is super rare in horses. Some toxins, yeah, like ethylene glycol, maybe aspirin overdose, but again, rare. Lactate and kidney issues are the main players.
Got it. Okay, shifting gears. Normal anion gap, NAGMA, you said losing bicarbonate.
Definitely the most common cause. Gastrointestinal bicarbonate loss. Severe diarrhea, acute colitis again, just pouring out bicarbonate.
So the same diseases causing HAMA via lactate can also cause NAGMA via bicarb loss.
Sometimes, yes, or one can predominate. Proximal enteritis, some small intestinal obstructions also lead to significant fluid and bicarb loss. This is a massive outflow of base.
And the other key NAGMA cause you flagged, the one vets might cause?
Ah, yes. Exogenous chloride administration, giving large volumes of certain IV fluids, specifically 0.9% saline, normal saline.
Because it's high in chloride.
Exactly.
Yeah.
It has way more chloride than horse blood normally does. Give too much, you dilute the horse's bicarbonate and load them up with chloride. Result, hyperchloremic, normal anion gap acidosis.
Wow. That's kind of scary. That treatment needs careful thought.
It absolutely does. Fluid choice matters. Other NAGMA causes are pretty rare, specific kidney problems losing bicarb, certain drugs. But GI loss and saline overload are the big ones to know.
Okay, so how do we actually spot this? The signs sound general. What are you looking for in the horse?
You're right. They are often nonspecific. Signs of the underlying colic or kidney failure, whatever it is. But things linked more to the acidosis itself or the body trying to cope. Depression, weakness.
And breathing changes, you mentioned that.
Yes, definitely look for changes in breathing. Often an increased rate, faster breathing, sometimes deeper too.
Panting.
Could look like that. The body's trying desperately to blow off CO2 because CO2 is acidic, remember, trying to compensate. That deep, rapid breathing is sometimes called Kussmaul breathing.
So it's the body trying to fix the KH itself.
Exactly. It's a compensatory mechanism.
Yeah.
You might also see signs of poor circulation if shock is involved, pale gums, cold legs, fast heart rate, maybe even a low body temp.
But you can't diagnose just by looking. Need tests.
Absolutely essential. Clinical signs alone aren't enough. You need lab work.
And the gold standard test is?
An arterial blood gas,
ABG.
AB. That gives the most accurate picture. The blood pH, the bicarbonate level, and the CO2 level, past CO2, showing how the lungs are compensating.
What are you looking for in the ABG?
Low pH, definitely. Low bicarbonate. And something called a negative base excess, or BE. It's just a calculation that reflects the overall base deficit in the blood.
Arterial samples can be tricky to get, right? Can you use a regular vein blood gas, a VBG?
Yes, and it's very commonly done. Less invasive. The sources say for the metabolic side, the bicarbonate and base excess VBG correlates pretty well with ABG. The pH and CO2 might differ a bit, but it gives you crucial info. It's practical.
Okay. What about just a standard blood panel? What's useful there?
Serum biochemistry, yeah. The total CO2, or TCO2, measurement on a standard panel is usually a good estimate of bicarbonate. Quick and easy.
And electrolytes.
Need those. Sodium, chloride, potassium. You need sodium and chloride to calculate that anion gap we spent time on. And imbalances are common anyway. Low sodium, low chloride with GI losses. Maybe high potassium sometimes.
And you absolutely need to measure lactate.
Crucial, especially if you suspect HAGMA. Measuring blood lactate directly confirms lactic acidosis. If it's high, say, over 2 or 3 millimole, that's a worry.
And you track it over time.
Yes. Serial lactate measurements are incredibly important. Seeing that number come down with treatment is a really good sign. Tells you if you're winning the battle against poor perfusion. Helps with prognosis too.
So diagnosis is the whole picture. Horse, blood gas, biochem, lactate. Now, treatment. The sources were really emphatic about one thing.
Yes. Absolutely crystal clear. The most important step, number 1, top priority, treat the underlying cause.
Always.
The acidosis is usually just a symptom, a consequence. You have to fix why it's happening.
So if it's poor perfusion from a bad colic causing lactic acidosis.
Aggressive 5E fluids. Poor fluids in balanced crystalloids like LRS are often preferred over saline here. Large volumes to restore circulation, improve tissue oxygen delivery, treat shock.
And if surgery is needed.
Then surgery, fix the twisted gut. The fluids also help dilute the acid and support the kidneys flushing things out.
Okay. And if it's negume from diarrhea, bicarb loss.
Again, aggressive 5E fluids are key. Replacing those massive fluid and electrolyte losses.
Yeah.
And of course, treating the cause of the diarrhea itself.
Kidney disease, toxins, treat those specifically.
Exactly. Treat the primary problem.
Yeah. What about just giving bicarbonate directly? To raise the pH, the sources seemed hesitant.
Controversial.
Extremely controversial. It needs to be used with extreme caution, if at all, and strictly guided by serial blood gas results. It's generally reserved only for very severe, life-threatening acidosis.
Like pH really low. Yeah, the sources mention thresholds like pH below 7.2, maybe 7.25, or a base excess that's really negative, like less than -8 or -10. Really severe cases.
Why so cautious? It seems logical. Low bicarb, low pH, just add bicarb back in, right?
But it's not that simple. That's the nuance. Giving IV bicarbonate might raise the pH in the blood, sure, outside the cells, but it can actually make the acidosis inside the cells worse, especially in lactic acidosis. And that intracellular acidosis can really impair the function of vital organs like the heart.
Whoa. So it could look better on the blood test, but actually be harming the horse at a cellular level?
That's the concern, yes. Another major risk. Bicarbonate metabolism generates CO2.
Right, we said CO2 is acidic.
Exactly. So if you give bicarb, you make CO2 if the horse is already struggling to breathe or can't ramp up ventilation enough to blow off that extra CO2.
You could actually worsen things. Give them respiratory acidosis on top of metabolic.
Precisely. It can overwhelm their compensatory mechanisms. Plus other risks. Overshooting the mark and causing alkalosis, which is also bad. Electrolyte shifts like low potassium, low calcium, sodium overload from the bicarb solution itself.
Okay, so lots of potential downsides.
Huge downsides. The sources even give formulas for calculating a dose, but they stress only giving maybe a quarter or half the calculated deficit, then immediately rechecking blood gases to see what happened. It's very careful, very monitored.
So rule #1, treat the cause. Rule #2, fluids, fluids, fluids. Rule #3. Bicarbonate is a last resort, high-risk tool for the severely ill, used with extreme caution.
That sums it up perfectly. And don't forget supportive care, pain management, fixing other electrolytes, nutrition.
And monitoring must be nonstop.
Absolutely. Constant monitoring. Watching the horse's clinical status. Are they brighter? Gums pinker? Breathing easier? And critically, serial blood gases. Essential to track progress and guide any bicarbonate therapy.
And tracking lactate trends.
Super important. Is lactate coming down? That's a key indicator of response, especially in shock or colic cases.
What about the prognosis? If a horse develops metabolic acidosis, what are their chances?
It goes straight back to the underlying cause. always. Prognosis depends entirely on what caused the acidosis and how severe it is, and if it's treatable.
So mild acidosis from, say, treatable diarrhea.
Probably a good outlook with appropriate fluid therapy, but severe lactic acidosis from, profound shock due to a ruptured bowel or an untreatable twist.
Especially if the lactate stays high despite everything.
Then the prognosis is grave, very poor. The acidosis level, especially lactate, and how it responds to treatment is a powerful prognostic indicator, but it reflects the severity of the underlying disease.
So the acidosis is more a marker of how sick the horse is from something else.
Often, yes. It's a sign that the primary problem is really serious, potentially life-threatening.
Okay, final piece. Prevention. How can we, as owners or caregivers, try and stop this from happening?
Well, you focus on preventing the common underlying causes,
Yeah.
which means good basic horsemanship, really.
Like colic prevention.
Exactly. Sound colic prevention practices.
Mm-hmm.
Consistent feeding schedule, lots of forage, constant access to fresh water for hydration, regular dental checks, good parasite control, the fundamentals.
Basics really matter here.
They absolutely do. And, crucially, recognizing colic signs early. Don't wait. Get veterinary help promptly. That could be the difference between a simple issue and one that escalates to severe gut compromise and lactic acidosis.
And for the vets, being careful with fluids.
Right. Using IV fluids judiciously. Choosing the right type, maybe avoiding massive amounts of saline if possible, and the right volume to avoid causing that iatrogenic angioedema, and of course managing any other underlying diseases like kidney issues.
So wrapping this up, what's the big picture? Equine metabolic acidosis, it's not just one thing. It's this critical imbalance, low pH, low bicarb, usually a signpost pointing to serious trouble underneath.
Often trouble with the gut blood flow, fluid loss, or sometimes the kidneys. And figuring out if it's high or normal anion gap helps narrow down that cause. Is it new acids like lactate piling up, or is it bicarb pouring out?
And treatment is all about fixing that underlying cause first and foremost. Fluids are key. Bicarb, maybe sometimes, carefully, for the critically ill.
Very carefully, with lots of monitoring.
All right, here's a final thought, something for you listening to mull over. We just talked a lot about complex physiology, acidosis, lactate. But given how central basic things, hydration, gut health, good management are to preventing the causes of this acidosis, how much focus are you putting on those fundamental day-to-day practices that can potentially stop this whole metabolic crisis before it even starts?
It really does hammer home how much that basic care connects to these really complex, serious health outcomes, doesn't it?